Hello, everyone, and welcome back to CleanMedKE, where we keep clinical medicine and surgery clear, structured, and clinical. Today, we're embarking on a detailed clinical primer on Ebola virus disease, focusing on the latest protocols for transmission, diagnosis, and management. Before we begin, a brief medical disclaimer. This content is for educational and informational purposes only. It is intended for healthcare professionals and students and does not constitute medical advice. To understand the severity of this disease, we have to look at its biology. Ebola belongs to the Filoviridae family, specifically the Ebola virus genus. While there are 6 species, 3 are the major players in human outbreaks: the Ebola virus, EBOV, the Sudan virus, SUDV, and the Bundibugyo virus, BDBV. The statistics are sobering. We see an average case fatality rate of approximately 50%. However, this isn't a fixed number. Depending on the specific outbreak and how quickly the clinical response is mobilized, that rate has historically fluctuated between 25% and a staggering 90%. This reinforces why every minute counts once a case is identified. Ebola moves in a cycle we call the ecology loop. It starts with zoonotic spillover. The natural hosts are fruit bats, and the virus can spread to intermediate vectors, typically ill or dead wildlife in the rainforest, like primates or antelope. Humans usually get infected through direct contact with the blood or organs of these animals. Once it enters a community, it creates a human-to-human web. This happens through contact with bodily fluids, contaminated surfaces, called fomites, or exposures in healthcare settings when infection control fails. We also see significant spread during unsafe burial practices involving contact with the deceased. One vital clinical rule to memorize: patients are not infectious during the incubation period. They only transmit the virus after symptoms start, and they remain infectious as long as the virus is in their blood. Safety is the foundation of management. For all patients, we maintain standard precautions: hand hygiene, respiratory etiquette, and safe injections. However, the moment a case of Ebola is suspected, we must shift to extra precautions. This means full personal protective equipment, PPE, to block every possible splash or contact point, isolating the patient in a dedicated center, and following rigorous protocols for contaminated linens and clothing. There is also a critical biohazard warning. Every patient sample is an extreme risk. Labs must use maximum biological containment and triple packaging systems for any transport to ensure the safety of the staff and the public. Recognizing the stages of the disease is key to triage. Phase 1 is incubation, lasting 2 to 21 days. The patient feels fine and isn't contagious yet. Phase 2 is the early stage, marked by a sudden onset of dry symptoms: high fever, profound fatigue, malaise, severe muscle pain, headache, and a sore throat. As it progresses to Phase 3, the wet symptoms appear. This includes gastrointestinal distress, vomiting, diarrhea, and severe abdominal pain, alongside systemic issues like a rash or impaired liver and kidney function. I want to highlight the bleeding misconception. Massive external bleeding is actually rare and usually occurs very late. Instead, look for internal bleeding: blood in stools or vomit, or mucosal bleeding from the gums or IV sites. Diagnosing Ebola early is difficult because it mimics so many other diseases. Malaria presents with similar fever and fatigue, but you can differentiate it by cyclic fever patterns and a positive blood film for Plasmodium. Typhoid fever also shares the abdominal pain profile, but look for a stepladder fever and rose spots, confirmed by Salmonella cultures. Even respiratory viruses, like COVID-19 or the flu, share early symptoms like a sore throat. However, those usually involve a prominent cough or shortness of breath, which are typically absent in the early GI-heavy presentation of Ebola. The biggest clues for Ebola are always travel history to an outbreak zone and the suddenness of fluid loss. To be certain, we turn to the lab. RT-PCR is the gold standard, detecting viral RNA during the acute phase. We also use ELISA to check for the systemic immune response, and antigen capture rapid tests to identify viral proteins. Virus isolation via cell culture is possible, but restricted to high-level reference labs. Again, the biosafety warning remains. Never test non-inactivated samples without maximum biological containment. While we have new drugs, survival is built on optimized supportive care. The data is clear. Early care equals increased survival. There are 4 pillars here. Aggressive rehydration, using ORS or IV fluids to replace the massive volume lost through GI distress. Symptom management, using pharmacotherapy for pain, nausea, and fever. Nutritional support, keeping the patient's metabolic function stable. Co-infection management, treating for regional pathogens like malaria empirically. The treatment options depend entirely on the species. For the Ebola virus, EBOV, we've made huge strides with monoclonal antibodies like MAB114, onsumivab, and REGN-EB3, Inmase, plus approved vaccines like Ervebo. However, for the Sudan and Bundibugyo species, we currently have no approved therapeutics or vaccines. In these outbreaks, management relies strictly on the supportive care pillars we just discussed, although candidate products are being tested under research protocols. Finally, we must care for survivors. The virus can hide in immune-privileged sites. It persists in the brain and CNS, leading to long-term psychological and neurological issues, and in the eyes, where it can cause severe uveitis. It also lingers in pregnancy-related fluids and breast milk. Most critically for public health, there is a high risk of sexual transmission. The virus has been found in semen up to 15 months after recovery. The protocol is clear. Survivors need monthly semen testing until 2 consecutive negatives, or they must use safer sex practices for at least a full year. That brings us to the end of this clinical primer. If you found this detailed walkthrough helpful, please like and share this video with your colleagues, and make sure to subscribe to CleanMedKE. Thank you for watching. We'll see you in the next video.